the examination, there's a verbal consent part, isn't it? Okay. Perhaps for a shoulder, you can also make one quick remark that the examination might be a bit uncomfortable at some point. Senang kata sakit lah. So just to warn the patient, most of the time they will have some pain. So we heads up the patient. Okay, right? Carry on.
Okay, so I would like to expose the patient, and I would like to look if there's any scar, or if there's any bruises, any muscle wasting, any atrophy, and then basically that one is for inspection.
Yeah, so for that purpose, you're going to have to show the examiner that you're looking from all directions, which is for the right shoulder case, you need to look from the side, so the back, side, and also the front. Okay, alright? You can always ask patient to turn if the space doesn't allow you. That's what happens in short or long case in the exam ward, and you're confined in that, what do you call, tirai tu kan? So you can't really push macam ni kan? So you can ask patient to turn if they are not in pain on the lower limb or something. Okay?
Alright.
Ask him to turn lah. Just they will do what you say usually. They are really compliant patients.
So encik pusing. Do I need to look for the?
Perhaps no. Okay, carry on.
So after inspection, I would like to move on to feel.
No, you should show us that you're looking from the front because we want to see the shoulder contour, right? We want to see the bulk of the deltoid. We want to see whether the deltopectoral groove is empty, for example. And last but not least, muscle and contour lah, basically. Yang paling penting. So you suruh dia pusing dan tengok macam tu, okay, baru you boleh commit. There are no deltoid muscle wasting. Then tadi from the back, apa you kata tadi? No periscapular muscle wasting. Faham? Okay, alright. It's showmanship, my friend. We need to know that you know. Faham tak? If you don't tell us do that way, susah nak bagi markah. Nanti dia tanya, kau tengok ke wasting tadi? Tak nampak pun kau tengok. Dia dah bazir masa kat situ. Good, carry on.
So encik boleh menghadap saya. So there's no muscle wasting anteriorly and also posteriorly, and also on the deltoid side. And I will move on.
Carry on.
To feel the patient.
Carry on.
So the temperature is normal, and there's no tenderness in the patient.
So again, the tenderness you have to go by the bony prominence. Yeah. So you work from the sternoclavicular joint. Okay, alright? Yeah. Okay, can you feel the acromioclavicular joint? Can you feel it? You think it's there? Yeah, acromioclavicular. So one, because not exposed. Number two, because you're not used to palpating, right? So you'll find that palpating is not as simple as you would think. It is not very prominent pun. Dia punya step off tu sikit sangat kan, betul tak? Okay? So let's work it out. Okay, I hope you don't have pain there. But if you follow the clavicle shaft until the it's here. It's here. Feel it? There's a bit of a dip. Okay, so you can try on your housemate later. It's just not that easy to feel. Okay, the clavicle memang naturally memang ada curve, isn't it? Like that curve kind of thing. So where the curve is not where the joint is. You have to go all the way to the lateral. Next, where do you go? No, palpation. You're not done yet, my friend. You're until ECG saja. Next. The glenohumeral per se is not that palpable because again it's surrounded by deltoid, isn't it? So what are you trying to look for actually? Now, after the ACJ, you move on to the acromion. Okay, kan ada acromion fracture, let's say you miss, so you didn't palpate the acromion. Then you follow the acromion to the back. Bagus. Okay. Okay, yeah, you can show your friend. Okay. Ni daripada sampai acromion ni punya bucu ni pergi belakang ni pula. Ni spinal scapula kat sini. There you go. You can up atas lagi. Tu muscle tu. There you go. Yeah. You can feel the bone, right? Yeah. Okay. All the way to the midline. And for completion's sake, you can always palpate the medial border and the lateral border of scapula as well, which is not so easily felt, but that's for your completion. Right? Yeah. Okay, next is apa tadi? I cakap kena palpate. Supraspinatus, you can try. Okay, alright. So how do you look for it? From the acromion, so being acromion, then you feel like a sulcus kind of thing, isn't it? So it should be deep to it. But again, not that easy to feel if you have pathology there because of the bulk of the arteries. Okay. What is more critical one I say just now to feel? Yes, the bicep tendon. You want to give it a go? In anterior. Here you can feel, you can roll something. Yeah? Quite annoying, isn't it? But if you have a tendonitis, lagi sakit. Memang itu memang. Tapi kalau sekadar rasa macam quite ni saja, it is not really a finding. It's just quite normal. Good. What's next?
And then I move on to next step.
Say again.
I move on to the test for the range of movement.
Range of look, feel, move, isn't it? Okay, alright. Carry on.
So I would like to start off with abduction.
Okay.
Then
Abduction setakat tu je.
then
You see the picture just now of that guy? Until where the
Until-
abduction?
until-
All the way up, isn't it? So ask him to do all the way up.
straight and go down.
Okay.
And shoulder.
So let's say you can go only until here. You can go until here only. So what is the finding? How many degrees is the abduction?
90, 100.
Yeah, betul. Just more, slightly more than 90. I think maybe 90 saja. You can even see patients sometimes because of the shoulder pain and stiffness, they try to compensate by do a lateral flexion of the trunk, but they want to perform as much as possible, right? But the true, of course, is from the trunk to the arm, lah. Okay.
And then adduction.
Adduction, yes, not critical, but you can do it. Okay.
And flexion and extension.
Okay. How do you do that?
Flexion first. Up.
Yeah. So this one you need to see from the side, lah. You see from the side. So you want to see how much he can flex. Okay, alright. For example, in this condition, again, is how many degrees?
90 degrees.
Yes. Bear in mind that each of this movement you ask them to move. That's okay, swing ke depan dia banyak mana boleh pergi? Tekan ni ya. Oh, boleh pula. Boleh pula sakit. Tekan. Ni maksimum cik sakit kalau tambah. Saya pula try tambah. Kalau sakit sangat cik bagi tahu lah. And then you try to add the passive motion. Okay, alright. Tak sakit pun. Kalau tak sakit maknanya passively you can go more. So maknanya the active flexion is 90 degrees, but the passive flexion is until, let's say kalau kat sini berapa? Let's say lah 150 degrees macam tu. So that's how you report the range of motion finding or whatever degrees there is. Have you come across the term massive rotator cuff there? From your reading, do you know drop arm sign? Is it there? Drop arm sign? No. So in a massive rotator cuff tear, they can't even go above the shoulder level. But when you help them like just now, boleh pergi actually, bukan sakit sangat kan? It because of severe weakness only because of the big rotator cuff tear. Okay? Carry on.
And then extension.
can, alright, although not super critical, but for completion sake, you can do extension. What I like to do is you do both at the same time. If presumably normal shoulder, you can go all the way, then this one limited, it will be a nice demonstration when you see from the side. So you can see normal 180, but abnormal is 120 saja, something like that. Same goes for extension, right? So if one can go like this only, the other one can go like this. It's very apparent that the right side is compromised.
Compare.
Yeah. So that can help. Carry on. You want to do rotation next? Okay, alright.
External rotation.
So how many degrees would you report the external rotation, for example?
External for this is 90, and then for internal rotation, that's 90 degrees.
Yeah, I think that's a reasonable estimate. Although in reality, probably you're off by, but it's okay. So that's a good start. Okay, that is for the range of motion. Okay. What's next?
After that, I would like to proceed to special tests.
How about for a stiff shoulder, or you can't give it up past 90 like your agile patient? Yeah. So we are then cik siku rapat ke badan, okay. Lepas tu buka keluar macam ni. Boleh tak buat? So tapi ni salah ni cik. Siku kena rapat ke badan, okay. Buka keluar, boleh. Okay. So let's say this shoulder is messed up, you can only do until here. So when you see from the top, you can imagine that this is 0 and this is 90. So he's probably around 30 saja, for example. Okay, alright. Dia tak payah accurate sangat pun. You eyeball okay lah agak-agak, tapi give a reasonable punya degree. Janganlah kalau dia buat banyak ni, like macam abduction lah, you calculation boleh tidak sini je, kan? Then you estimate 120, maknanya you salah sebab tak mungkin jadi 90 sini kan, betul lah kan? So maknanya kena bagi reasonable. Tak ada orang kata, ni 55 pun, tak ada kan? Faham kan? Okay, alright. Next. Look, you jam already kan? So back to the mantra. Apa mantra dia? Yeah, look, feel, move, special, yeah. Sebab it can happen like this. Either you buka bra, atau examiner interrupt you because they are annoyed by something or not clear about something, then you are. So look, feel, move, special. Then you see, okay, alright. Carry on.
I would like to proceed to special tests,
Okay.
which is specifically for the disease itself.
Yeah, but okay, alright. So you can probably try to guess only because you don't have the history in a short case, okay? In a young, fit guy like him, probably we bring him in because of recurrent shoulder dislocation. Ni bukan rahsia pun, it's an open secret. You know what your seniors get lah, kan? Shoulder boleh balik, recurrent shoulder dengan cuff, apa lagi, aku tadi bawa fracture kau, betul kan? So, okay, carry on.
Special test. I don't know, job test.
Nanti kalau instability, let's say, what do you think the test will be okay for him? More critical. You can test everything, you know. You can go through the list or even that long annoying list, but in the end you want to save time, kan? Betul lah. Kalau instability, usually they don't really have that impingement as their problem, but you want to get the instability punya symptom, betul lah, which is by the apprehension test. You can start with the drawer test first to see the direction of the instability. Do you think you can try drawer test from your reading? Maybe you can try.
I'm not sure. I'm not confident to do that.
Okay, alright. Tu kau tak baca sure lah. Cakap je lah kau tak baca. Okay, alright. So drawer test, you stabilize the acromion and you try to hold on to the proximal humerus. Betul tak? Again, difficult or easy? If the muscular susah lah. And then you try to grip the humerus and then you try to move it forward and move it backward to see mana yang kata more translation, more movement. Even you are struggling to feel on her, isn't it? It's not that easy, is it? Yeah. It's not like your knee drawer test, which can get difficult at times, but you know, okay. Drawer, okay. If tak ada lah, knee PCS tak ada lah. And then apa you buat next? Apa yang kata tadi? Test? Apprehension test. So either when patient standing or patient sitting up also can. Okay, alright. So again, let's say you face that. This is a passive test. So we ask patient to just relax saja. Okay, alright. First you bring to the abduction and external rotation punya position. Okay. Dalam ABER ni, usually they can go here, but they already inside their mind they feel not so secure, isn't it? But you always check with them. Since you can't see their face clearly, you can check verbally. Cik okay ke ni? Ada rasa nak terkeluar ke? Belum lagi kan? Tak ada kan? And then start to try to push here to get more of a leverage for your, to add on your external rotation and perhaps some extension as well. This will further push the head of humerus to the front, which is where the commonest direction is anyway. Alright? And then when we want to go further, then he will start to tense his muscle. But just now we ask him to relax kan, betul lah Tapi when you then rasa nak ni, then maknanya your test is already positive. There is of course an extension to this test. If you read book, they do it on a supine position, and when we rest it against the bed, macam nak jatuh ke belakang lah. But you put a pressure in front, maknanya kita nak bagi the head of humerus sublux ke depan. Okay, you will notice that he can go even further, extend to the back and external rotate more. But as you ease the pressure here slowly, you will start to feel unhappy and contracting the muscle again. Therefore showing that the apprehension test is positive. Itu kita panggil relocation test. Okay? For you keep it simple lah. Satu test, dua test dah cukup lah. Tak ingat pun answer lah. Okay? Cuff. Apa special test yang you dapat tadi daripada for the cuff tadi? Let's say it's a 60-year-old makcik with the right shoulder pain. Dah buat range of motion semua, ada some stiffness di sini. Apa special test you nak buat?
Special test.
Okay, perhaps help to remind him what test you want to do.
Hawking job.
You can do Hawking, you can do joke, okay, alright. Hawking is an impingement related test, okay. Do you perhaps recall how to do the Hawking? But more of a forward. The picture is right there, my friend. Okay, alright. So it goes 90 forward and 90 elbow, and then you further internal rotate. This is again a passive test. Okay, alright. And you notice that when you try to internal rotate further than the neutral, you will have problem. You will have pain. So you can use. I demonstrate here lah. Okay. Like this, see, and then when we push further, see how I lever it here to have a good internal rotation. Okay. Some books will ask you to do this, which I don't prefer because you are violating quite a private space of the patient, especially in female. So I think if you do this, it's already quite acceptable. Okay, alright. That's just my opinion. Okay, alright. Yeah, you can test the integrity of the supraspinatus by doing the joke test. Okay. Can you perhaps demonstrate? Okay, depending on which book you use, but what I'm familiar with is a 15-degree off the midline. What book you use for the examination?
I'm not sure.
You're just like that girl, you're taking video lah. Later she don't have reference. You can watch all video. In YouTube, they have much nicer video than what I demonstrated. Don't take video lah, my friend. You just listen and understand. But you need to have reference, book reference. Sebab sometimes teknik can vary. Kalau kau cakap siapa ajar kau, Johan ni ajar. Johan tak laku lah, tak laku. You literature yang laku, textbook yang laku, peer reviewed punya published literature. So Apply for example kan, Apply punya book hukum. Oh you pakai apa? MacRay is it?
Apply.
Orang pun tak tahu. Okay, alright. Kita orang dulu master pakai Rider, buku lama lah, buku hitam putih punya buku. So nak kata apa? 15 degrees off the midline or whatever, okay, alright. And then kononnya inilah yang paling akan isolate your supraspinatus. And then try to resist it, not passive, this is active, okay? Because we want to test the power, okay, alright? Therefore, in this internal rotation, then we push down and then you push up. Lawan tangan saya, Encik. Oh, kuat, bagus. Tak sakit kan? Oh, bagus. Negative. Faham kan? But more often than not, you will have some pain tak apa lagi. Kalau you weak, you're going to jolt positive. Dia takut ada rotator cuff there. Naturally, again, in a stiff shoulder, what do you think will happen when you ask them to do? It will be damn painful lah, although it is not torn. Therefore, that's why in clinical practice, sometimes the stiffness can mask your special test. Therefore, that is your limitation. In exam, if you get positive, it's okay. It's positive, it's positive. Okay, alright. Great. And just now, the frozen shoulder, nothing interesting. Just